Hello, I'm Dr. Bhavana Pothuri, a gynecologic oncologist at the NYU Grossman School of Medicine and Perlmutter Cancer Center in New York City. Welcome to this educational activity entitled Targeting with Precision in Advanced Ovarian Cancer, Integrating Approved and Novel Agents into Personalized Treatment Plans. I'm pleased to be joined by my colleague and friend, Dr. Pothuri Thaker, a gynecologic oncologist from the Washington University School of Medicine and Siteman Cancer Center in St. Louis, Missouri.
Thank you so much for having me today, Bhavna, and thank you to our viewers. I'm excited to talk about the latest therapeutic data and practical tips for treating patients with ovarian cancer and highlighting some of the exciting updates from the SGO annual meeting in Puerto Rico a couple of weeks ago.
Great. Thank you to PeerView and the National Ovarian Cancer Coalition for providing this session, and GSK, Insight, and Veristem Oncology for providing the educational grants for this webcast. Just as a reminder, please respond to polls when they pop up on your screen and enter your questions for us in the chat window. The slides and practice aids can now be accessed in the activity menu and downloaded after the session. Let's get started. So today's goals will be to understand the clinical evidence for the numerous approved and investigational therapies in the management of ovarian cancer, to understand how we can incorporate novel strategies to individualize treatment plans and maximize patient outcomes. And finally, how we can integrate team based approaches to educate our patients and improve the safe delivery of these novel therapies. So, currently, we have many treatment options for patients with advanced ovarian cancer, in addition to the standard surgery and chemotherapy. We have PARP inhibitors in the frontline maintenance setting and recurrent um, uh, maintenance setting, as well as antibody drug conjugates. More recently, the incorporation of checkpoint inhibitors and other novel targeted therapies. So, today we're going to be talking both about low grade serous ovarian cancer and high grade serous ovarian cancer. And I want to just point out some differences between these two diseases. High grade serous ovarian cancer is more common. When compared to low grade serous ovarian cancer, high grade ovarian cancer usually is the median age of diagnosis is around 50 to 60, whereas the low grades have a bimodal peak, 20 to 30 and 50 to 60. The molecular makeup are very different for high grade and include P53 mutations commonly, BRCA, HRD, and they tend to be wild type in terms of BRAF and the RAS MAP kinase pathway. Um, while the low grade serous are wild type P53, but often have aberrations in the RAF pathway. In addition, their responses to chemotherapy are very different. High grade serous ovarian cancers are exquisitely chemosensitive, while low grades have much lower response rates to chemotherapy. So, the other thing I think that is important is to understand that, while all low grade serous ovarian cancers have lower response to chemotherapy when compared to high grade, and they're not driven by BRCA or HRD and are P53 wild type. There are two distinct groups within the low grade category. The older patients are the ones that tend to have the higher rates of the MAP kinase alterations. They have more indolent disease. They respond better to those newer targeted therapies that we'll be discussing later and have better prognosis, while it is the younger patients who are diagnosed at that very early age who have lower rates of those MAP kinase alterations and have more aggressive disease and actually worse prognosis. So with that, let's think about some cases, and we're gonna I'm going to have you, I'm going to introduce these and then we'll get back to them later. So, Cheryl is a 66-year-old with stage 3C high grade serous epithelial ovarian cancer. She's a retired teacher. She enjoys sewing and visiting her grandkids, while Amanda is a 50-year-old with a stage 3 low grade serous epithelial ovarian cancer. She's an attorney. She coaches her daughter's soccer team. So, things I want you to think about as we go through this data is one, is biomarker testing important? Two, what treatment options do we have for these two patients? And, what are things that we need to think about that are unique to these patients and their quality of life? So, I also wanted to point out that we have some very important educational material available for patients. And the NOCC, or the National Ovarian Cancer Coalition, has a number of resources online at ovarian.org. So, I think is a really nice resource for patients as they're going through their cancer journey. In addition, the NCCN has guidelines for patients that use plain language to explain. The recommendations for people with cancer. And then finally, the NCI, cancer.gov, as well as clinicaltrials.gov, has information about cancer prevention and screening. And then really the go-to website for the active clinical trials is clinicaltrials.gov. So let's talk a little bit about PARP inhibitors. And so I want to just talk about these are kind of, this is the summary of the updated recommendations for PARP inhibitors in the frontline maintenance setting. So these are indicated for patients with newly diagnosed stage 2 to 4 who've had a complete or partial response to platinum-based chemotherapy. And based on their biomarker status, they have different options. So, if a patient is germline or somatic BRCA1 or 2 mutation carrier, they have the opportunity to utilize olaparib or niraparib based on SOLO 1 and PRIMA data. In addition, BRCA1 2 mutant carriers also can utilize the Paula 1 regimen, which is olaparib and bevacizumab. Now, if patients are HRD positive, they have the ability to utilize Prima as a single agent niraparib, or they can utilize the combination with olaparib and bevacizumab based on the Paula data. And then there is, Ovario, which is just a single arm phase 2 trial that utilized niraparib and bevacizumab, and is NCCN 2B listed as a treatment option. If a patient is BRCA negative and HRD negative, there at the current time there is not a recommendation to utilize a PARP inhibitor in this frontline setting. Um, so, what about in the platinum sensitive maintenance setting? So, in patients who have had a CR or PR to platinum based chemotherapy and have not used PARP in the frontline setting, um, if you are a BRCA germline or somatic mutant carrier, you will be able to use either olaparib or niraparib. And if you are HRD at this time, there are no recommendations for PARP inhibitors. And if you're BRCA or HRD negative, same, no recommendations. So, really, you can see how this window has been narrowed. I wanted to quickly run through the data utilizing um, PARP. So Solo 1 was the first trial that reported out. This was only in BRCA mutation carriers. You can see here the progression free survival at the 5-year follow up. Um, Really impressive. The hazard ratio was 0.33. And then the overall survival at the 7-year follow up, the hazard ratio was 0.55, with a 45% reduction in the risk of death due to ovarian cancer with the use of olaparib. And then here are the Paula 1 data, which is the combination of olaparib and bevacizumab. This is the overall survival data. And you can see here in the BRCA mutated patients that there was a hazard ratio of 0.6 with a 40% reduction of death. Um, And then in the HRD positive, excluding the BRCA mutation carriers, this was 0.71, and there was no benefit in the HRD negative. And currently, the use of this regimen is limited to those that are BRCA or HRD positive. And then let's talk finally about Prima, which is utilizing niraparib after first line platinum based chemotherapy. And then, we'll focus on, this on the top, you see the progression free survival data. Um, and you can see that there appears to be benefit across groups. However, when we look at the overall survival data, there appears to be no difference, both in the overall population, the HRD population, or the HRP. And so, with this data, the PARP approval was narrowed down to the overall and the HRD, given this benefit. Um, so, um, with all new therapies come adverse events, which are important to keep in mind, so we can utilize these and manage our patients in a safe manner. So the hematologic are very common: anemia, thrombocytopenia, and neutropenia. Um, and then, but these are easily managed with dose holds and dose reductions. In addition, the non-hematologic nausea, vomiting, asthenia, diarrhea, or constipation, really making sure that we utilize antiemetics, and also counseling the patient that most of these side effects actually diminish with time, is really useful in terms of maintaining patients on therapy. And then, of course, we can't forget the rare side effects: AML, MDS, and pneumonitis. I think we talked about nausea, the importance of prophylactic antiemetics, encouraging patients to have small meals. And then, actually, if they're taking niraparib, they can take the medication since it's just once a day, they can take it at bedtime. So that may be a strategy. And then with insomnia, if nausea is not a concern, they can take and if it's just something like niraparib that's once daily, they can take it in the morning. Both of these cause bone marrow suppression. So, the niraparib does have a higher risk of thrombocytopenia, which is why we need to monitor those counts, weekly for the first month, as opposed to olaparib, where we can do a baseline and then I tend to do it in 2 weeks, but the recommendation is it can be done 1 month later. And then finally, fatigue. Fatigue's a hard symptom, and it's impactful to patients. So really, considering dose interruption or dose reduction, encouraging exercise, and sometimes even a small nap during the day can be beneficial. So let's get back to our case. This is Cheryl. She's a 66-year-old with stage 3C high grade serous ovarian cancer. She is a retired teacher. She likes to sew and she likes spending time with her grandkids. So her comorbidities include high blood pressure and IBD. She recently finished her 6 cycles of carboplatin paclitaxel. Her her testing, she was a BRCA wild type. She was HRD positive, PDL1 negative. FR alpha was 70%, and her HER2 IHC was 1 plus. So, Prima, let's talk. What do you think? How would you treat her, and how would you counsel her? In terms of a maintenance therapy.
I think, thanks for that excellent presentation and reviewing the data. It's always nice. So she has several options, right? Since she's HRD positive, she could take a PARP inhibitor alone, like niraparib, or based on the data Paola, she could be on a PARP inhibitor like olaparib with bevacizumab. I have to say, for us, we typically don't sort of add bev as a maintenance with our PARP afterwards if they weren't on it upfront. We just sort of don't believe in a switch maintenance because that's not how the trial was done. So I would offer her niraparib typically for this patient. And I think patients are excited to get oral medications because, for in the breast cancer world, they've had oral medications forever. I know you probably have patients who are like, why do I even take chemotherapy? Why can't I just not start with an oral medication? And we're not there yet. So I think they're very happy to go onto an oral medication.
Yeah, we do exactly the same thing, Premo. If we haven't started the bevacizumab, and this is not a patient that I would have started, she's a 3C, didn't have, the high risk features, so we would have treated her with carboplatin paclitaxel, and then I would utilize, the single agent niraparib. But had I started her on the bevacizumab, then I would have, you know, I would certainly continue the bevacizumab and add olaparib. And then, how do you ensure adherence of the oral medication? And then, how do you also discuss labs and AEs with your patients?
Usually what we do is I have my nurse check on the patient to ensure that they're taking the medicine. Since it's a once daily medication, it's a little easier, right, to remember once daily pills compared to twice a day, especially in a patient who might be taking an antihypertensive and taking it just once a day, a long acting. And then, we do emphasize the need for labs. So that's another great way to remind the patient that, oh, your labs are upcoming too, as well as making sure that they're taking their medication because those hematologic adverse events, like you mentioned, of the lower white count and, thrombocytopenia are really opportunities for us to prevent complications. And if we need to, even dose reduce patients as well early and also make sure they're tolerating it because if they're not tolerating it, of course, they're not taking it and not getting the benefit.
Yeah, agree. I mean, it's really how we keep on top of these patients is really important. And I think you mentioned the other thing that was really important too is you're making sure your whole care team, like your nurses and APPs, like are understand the side effects and know what to do when the patient calls. So I think that's really important as well. What other questions do patients have regarding their treatment effects?
In terms of how it affects their day-to-day routine, I think, is one of those things that we talk about all the time in clinic because we really wanna make sure they're maintaining a quality of life on the maintenance phase. Not that we don't try to maintain that quality throughout treatment, but I think it becomes even more crucial when we're maintaining the response so they can have that active life back.
Agree. Agree 100%. All right. I think we're going to move on to antibody drug conjugates. So, just to review, antibody drug conjugates are made up of an antibody as well as that recognizes a target antigen, as well as a special linker that then houses a cytotoxic warhead. So, in terms of the antibody drug conjugates that are currently FDA approved, we have two mirvetuximab, which has a DM4 payload that is a microtubulin uh, um, payload. And this is approved, FDA approved for FR alpha high ovarian cancer, and that's greater than 75% staining with 2 plus staining intensity. And that's for the second line or greater. And we also have trastuzumab deruxtecan, which is also, this one has a different, a topo 1 payload, targets HER2, and it's approved for the HER2 IHC 3 plus with a tumor agnostic approval. Um, so it's great to have these two, but I think there's many more on the horizon. And so sofetabart mipitecan was just the data I just presented at SGO. We have Rena S. We have Torvuda S, we have disitamab vedotin, we have BNT323 with or DB1303. So lots of and in addition to this, we have other antibody drug conjugates that are also actively under study. The TROP2, so SAC-TMT, SASI-govitecan, Dato-DXd. We have those that target B7H3 as well as CDH6, and we have the B7H4, the MoRes data, which was pretty impressive. That was presented at SGO, both in ovarian and endometrial cancer, as well as Puxi-Sam, which was also presented previously. So, in terms of targeting FR alpha, I already alluded to mirvetuximab. Mirasol was the phase 3 trial that led to FDA full approval in March of 2024. And you can see here there in terms of the median progression free survival. Um, it was 5.9 versus 3.98, but I think you really need to look at the hazard ratio, and this was a 37% improvement in progression free survival, highly significant. And then in the final analysis, when we look at overall survival, again, a 32% reduction in death. So, really impressive that we saw both. This was the first time that we saw both a PFS and an OS benefit in platinum resistant ovarian cancer. And so, this is now a treatment option again for those patients who are FR alpha high, so greater than 75% or and 2 plus staining intensity. So as I alluded to, we presented the Sophie M data at SGO. This is also an FR alpha targeting ADC, but has a topo 1 payload. And you can see here that there was efficacy across FR alpha expression levels. And in the entire cohort of 104 patients, the objective response rate was 50% with 4 complete responses. And the disease control rate was 78%. And I think one thing I'd like to point out here is this was the first time that we saw significant efficacy in the FR alpha ultra low, which we defined as 0 to 24%, where we saw an objective response rate of 40%. And so now there is a phase 3 trial that is evaluating Sophie M in platinum resistant ovarian cancer, in platinum sensitive ovarian cancer who've progressed on or within 6 months of completing a PARP inhibitor, or in in platinum sensitive ovarian cancer that are PARP naive. I want to really also focus on MoRes. This was also presented at SGO, and very impressive data. MoRes, it targets B7H4. And it also has this has a Resatican, which is also a topo 1 payload. Um, and what we saw was that we saw confirmed objective response rates from 31% at the lower dose, 2.8, up to 62% at the 5.8 milligram per kilogram dose. And the responses were observed across B7H4 levels. They were rapid and deep, and the hematologic profile was quite manageable. And there was an extremely low discontinuation rate. So, clearly, another very promising ADC. These are the randomized ovarian specific trials looking at MoRes. So we have a phase 3, that's the platinum resistant ovarian cancer trial, Behold O1, that randomizes MoRes to investigator's choice chemotherapy in platinum resistant ovarian cancer. We have then the phase 3 Behold Ovarian O2, which is MoRes versus chemo in platinum sensitive ovarian cancer. And finally, we have the Behold O3, which is MoRes in the first line maintenance HRD negative cohort. And then lastly, there is a MoRes and bevacizumab arm that's enrolling in the phase 1/2 Behold 2 study. I want to also just talk about Destiny Pan-Tumor O2. This is the TDXD tumor agnostic approval for 3 plus IHC. Um, and in ovarian cancer, the data's here. In the 3 plus, we saw 64% objective response rate. But I think it's important to keep in mind there were only 11 patients in this cohort. And, I think the Destiny O1 trial is underway. It is looking at TDXD plus bevacizumab versus bevacizumab as frontline maintenance therapy in HER2 expressing ovarian cancer. I think it's really important, as we talked about with PARP inhibitors, with all these ADCs that are emerging as very exciting therapeutic targets, we need to think about adverse events. So, in particular, when we think about the lung adverse events, ILD kind of sticks out in my mind. I think it's also important to think about ILD. It's different. The HER2 ADCs have a higher rate of ILD when compared to some of the other ADCs, but and so it's managed a little bit differently. So with the HER2 ADCs, you definitely need to hold even for grade 1 ILD. Corticosteroids are a core in terms of the management of ILD. Um, Additionally, ocular AEs are very important. We've all learned from mirvetuximab that keratopathy can be noted, and also blurry vision. So we do need to really have eye exams that are done before treatment, during treatment, and encourage our patients to utilize lubricating drops, as well as steroid drops as needed there, and avoid wearing contact lenses. The oral and GI adverse events are important, especially with the TROP2 ADCs that we've seen, as well as all the exatecan. There's a lot of nausea, vomiting, and those need to be thought of as, moderately emetogenic treatments, and prophylaxed as such. So we've discussed the impact of both PARP inhibitors and antibody drug conjugates for ovarian cancer, but there are many other new exciting regimens with different modes of action in this space. And Premal already alluded to some oral therapies. So I'm going to turn it over to her to take us through some of these exciting new options.
Thanks, Bhavna. So I do think there's a lot of exciting new therapies. For instance, we all have known that checkpoint inhibitors have really transformed how we treat endometrial cancer, but historically, we've not had much success with checkpoint inhibitors for ovarian cancer. So we've not had any overall survival improvement with monotherapy or combination approaches. We've tried in many different lines of ovarian cancer treatment upfront, platinum sensitive, and now with Keynote B96, we actually have gotten an approval for patients to use an immunotherapy in combination with paclitaxel plus or minus bevacizumab in our platinum resistant ovarian cancer patients. So, what did we see is that we saw a very statistically significant improvement in progression free survival, regardless of our PDL1 status. So you can see on the graphs that there was an improvement. And I think once again, it's really important to see the hazard ratio of an improvement, that there was a 30% risk reduction when you added pembrolizumab to this well tolerated treatment option for our patients. And then secondarily, we did see an overall survival benefit as well of 24% of a decrease in sort of progression for those patients who received the pembrolizumab. So once again, leading to an FDA approval in February 2026. And this is exciting because we're actually making improvements in platinum-resistant ovarian cancer. So we're, helping our patients live longer and more meaningful lives. And then there's other, mechanisms of action. Who knew that we'd be talking about the glucocorticoid receptor as being important in ovarian cancer therapy? So we know that ovarian cancers express glucocorticoid receptors, and it's been known to be a marker of poor prognosis. Glucocorticoid receptor signaling reduces the sensitivity to chemotherapy because it's really thought that it sort of makes it harder for the apoptotic pathways to work. So having relacorilant, which is a selective glucocorticoid receptor antagonist, restores that sensitivity of the cancers to the chemotherapy, so allowing more apoptosis. So it's a really novel way for our patients to be treated as well. So, what led to this exciting trial, which was also presented recently, the overall survival data by Dr. Alawiye at SGO, was the phase 3 Rosella trial, which utilizes nab-paclitaxel along with relacorilant. I think it's very important to understand it's nab-paclitaxel because you want to minimize steroid use when you're using a glucocorticoid receptor antagonist. And this had a very similar inclusion criteria for patients that they had to have um, platinum resistant ovarian cancer, but they were allowed to have at least one additional line of prior chemotherapy. And prior bevacizumab was required as well. So this is a weekly nab-paclitaxel that's given, and then the relacorilant is 150 milligrams, which is given the day before the administration of chemotherapy, the day of, and the day after. So for 3 days, do you get it as part of that weekly regimen? And it had dual primaries to look at both progression-free survival along with overall survival. And what they found is that relacorilant met its dual primary endpoints, meaningful differences for our patients that were able to get novel drugs and also a drug that is tumor agnostic. So it benefited all patients despite any subgroup analysis. Relacorilant has, of course, some adverse events, as we talk about with all these medications. Not anything comes without some side effects, but overall quite manageable with the long-term overall survival analysis that we just saw. There was no new side effects or safety signals that were found. Okay, so excitingly, we also have another novel inhibitor for CDK2. And why is CDK2 so important is that we know that it plays a crucial role in promoting G1 to S phase transition and S phase progression in the cell cycle. Cyclin E is a regulatory subunit of CDK2 and is responsible for its activation. So we've known that the dysregulation of cyclin E has been observed in multiple malignancies, and its overexpression has actually been associated with reduced survival in high grade serous ovarian cancer. So we know cancer cells with CCNE1 amplification are dependent on CDK2. So if we can inhibit CDK2, it can cause a synthetic lethal component with the CCNE1 amplification or overexpression. So ultimately leading to cell death for the tumor cell. So there's an exciting phase 1 study that was looked at using in INCB 123667, a CDK2 inhibitor, in patients who had advanced platinum resistant ovarian cancer. And so it was a typical phase 1, which had, all comer type of situation. Then phase 1B, though, was enriched for ovarian cancer, so platinum resistant as well as platinum refractory ovarian cancer patients. They could have had up to 4 lines of prior systemic therapy. They had to have CCNE1 amplification at their local laboratory, as well as a good performance status. They have 3 different doses 50 milligrams twice a day, 100 milligrams once a day, and 125 milligrams once a day. And then this was the waterfall plot that you could see. And you can see that over 70% of patients had a reduction in tumor size compared to baseline. And this was over all dosages, if you can see. So that's really encouraging, especially for such a platinum even refractory patient population that were included. So based on this, you can see the swimmer's plot and the single agent 100 milligrams daily of this medication had an overall response rate of 33.3% with a median duration of 3.6 months and a progression-free survival of 5.3 months. All responders had cyclin E1 overexpression, except for one had unknown status. And also the side effect profile was once again manageable with it mainly being hematologic and GI issues. So we're going into a trial that's called a phase 2 called Maestro 1. And it's really looking at platinum resistant ovarian cancer patients who had had to have prior treatment with bevacizumab unless contraindicated, or patients who had prior mirvetuximab if they had tumors expressing folate receptor alpha high expression. They will receive this novel agent at 50 milligrams twice daily. The cohort one is going to have 100 patients in it, and there will be high cyclin E1 expression. But cohorts two and three actually are trying to look if you need lower expressions of cyclin E1, which I think is exciting because we want to be able to give our patients more options. And so this will hopefully broaden the pool of patients that can receive this drug. Once we get phase 2 completed, we're rolling right into phase 3, which will combine looking at this novel agent versus investigator's choice chemotherapy. So stay tuned. And then, of course, there's a WEE1 inhibition for PROC patients with cyclin E1 overexpression. So we have the Denali trial, otherwise known as GOG 3066, which is an open label trial looking at the use of azenosertib in cyclin E1 with platinum resistant ovarian cancer. This allows for up to 3 priors and 4 if you've had prior mirvetuximab. So now let's take a look back at our patient case. As we mentioned before, she got her 6 cycles of chemotherapy followed by niraparib. Her testing results, now we know she has cyclin E1 overexpression, so that's an addition. So she progressed 9 months later after completing her niraparib regimen. So, what are her options? Because we've gone over a lot of different options with ADCs, checkpoint inhibitors, clinical trial. So, what are some other FDA approved options that you would consider, Bobna, for this patient?
Yeah, so she still has platinum sensitive disease, right? Because she completed 3 years of PARP and then she progressed 9 months later. And the idea is like, are these patients as sensitive to platinum at this point? And would utilizing a ADC be better than the standard platinum doublet chemotherapy with bevacizumab? So I think ADC plus Bev trial is what I would shoot for this patient. What about you?
Yeah, I completely agree. I do think there's some really novel platinum sensitive ovarian cancer trials with ADCs and Bev. And I think, it seems to be like probably the way we're leaning towards as we see the overall response rates from these ADCs and our platinum resistant. You only hope that a platinum sensitive will even do better.
Very exciting. And then if she was like platinum resistant, I think we have a whole bunch of other options, right? In terms of like the FR alpha ADCs for clinical trial, B7H4 target with MoRes, and then of course all the exciting, trials, the CDK2 trial that you're leading or WE1 trial. So, and especially with her cyclin E1 overexpression, I think that would be a nice like targeted approach.
I agree. And I think what's also nice is we also have FDA approved options since, some of the patients don't make it to our centers with clinical trials. So they at least have some options that are now, have great trial data with OS, overall survival data. So that I think is also exciting for our medical oncology colleagues who might be in the community and can't access us. So I do think there's a lot of great options now for patients.
Okay, so I think I want to talk a few minutes about the importance of access to clinical trials. This is an area that I'm very passionate about because I do feel very strongly that all patients should have access to clinical trials, and the patients that are actually expected to use the medicine should be represented in the trials so that we understand, both safety and efficacy in these patients. And I think so. This was really looking at some common barriers to clinical trial participation. There were also population specific barriers to clinical trial participation. And so, a lot has been done about how we address. Black patients. But so in this manuscript, we really sought to look at Hispanic and Asian patients. And these are really the physician and patient related obstacles and actionable solutions to each of these obstacles or barriers. And then, these are also, and within the same manuscript, we talk about the obstacles in terms of the support and care team, and patient navigators was a big theme in terms of really increasing the number of navigators and positioning them so that they can really help educate on disease states, available treatments, and the importance of trial participation. And then, the other solution that really came up was really involving nurses and APNs to be that support in the clinical trial setting. And then I want to turn it back over to you, Premal, to talk about NOCC. Yeah.
The great thing about NOCC is that they actually provide supports because we do know that there is a lot of sort of hesitancy sometimes to enroll. So having a peer support program is really important. So there's so many resources. So please look at NOCC at ovarian.org in order to find these resources for your patients. So I would like to sort of transition. We talked a lot about high grade ovarian cancer, but we also want to mention low grade ovarian cancer as well, because, as Bhavna mentioned earlier, it has a lower incidence, but it affects women who typically are younger and they have a longer median overall survival, but unfortunately, they present with advanced disease and recurrence, and it tends to still be a fatal disease and they have been excluded previously from our ovarian cancer trials that we have discussed just because the biology is so different. So we're still learning what other therapies we can offer. But so far, we've used chemotherapy and endocrine therapy, but the response rates have not been as beneficial for our patients. So we're still in critical need for additional tolerable therapies that give us more meaningful results for our patients. So, we learned a lot at SGO because we had our phase 3 NRG-GY019, which is for our upfront patients, which was a phase 3 that was randomizing patients to letrozole monotherapy versus carboplatin paclitaxel, followed by letrozole as initial treatment for platinum resistant ovarian cancer. And in this intention to treat population, the study met the pre specified futility stopping criteria and did not demonstrate that there was a non inferiority of letrozole monotherapy versus chemotherapy followed by letrozole. So it does cement that you should use chemotherapy of carboplatin, paclitaxel, and letrozole as the standard of care. So I think all of us were hoping for the reverse, but unfortunately, that's why we do trials so we can really see what does the data show and in an unbiased fashion. But as I mentioned, most of these patients are found in an advanced disease. So what do we do when they recur? So, as we had mentioned before, KRAS is known to be a critical pathway in low grade serous ovarian cancer. And we find that there's alterations in this pathway. And up until now, we've looked at MEK inhibitors by themselves. However, we've not seen as exciting results. So now we have this new combination called avutometinib and defactinib and it's pretty unique because it attacks sort of cancer biology in two ways. So, vudametinib is a first in class RAF and MEK clamp that potentially inhibits the MEK kinase activity while blocking also compensatory reactivation of MEK by upstream RAF. And I think that's critical because we think of biology as going vertical and down, but there's always resistance mechanisms. And also, importantly, we know that the FAC pathway has also been critical as well. And so now you have defactinib, which is a selective inhibitor of focal adhesion kinase and a proline rich tyrosine kinase 2. And so two members of this FAC family are being inhibited. And so by doing this, you actually get tumor regression. And so we know 70% of low grade serous ovarian cancers have a RAS pathway associated mutation, but 30% of them are really KRAS mutated specific. So we had the RAMP 201 trial, which was looking at the combination of this medications of defactinib and avutometinib. So it was for patients who had recurrence. They had to have prior platinum chemotherapy as well as measurable disease. And up to 20% of patients had prior MEK inhibitor allowance in this group, which I think is really great because we had so many patients who were exposed to prior MEK alone. And this is what we saw for the waterfall plot, which was super exciting to see, especially in patients who had a KRAS mutation. We had a confirmed overall response rate of 44%. And we had some complete responders as well as partial responders up to 40%. And I'd even say in the KRAS wild type patients, we did see a confirmed overall response rate of approximately 17%, which is in line with some of our other MEK inhibitors as well. So it has activity, but of course, the overwhelming activity was seen in the KRAS mutated population. So this led to FDA approval in May of 2025 for patients who had a KRAS mutated recurrent LGSOC. And as I mentioned, these patients had prior MEK inhibitor treatments up to 21%. So it's exciting to see that you could re-challenge patients with another type of KRAS mutator mutation inhibitor drug like avutometinib with defactinib and get even better results. So the long-term follow-up was presented at SGO by Dr. Grisham, and really what we saw is a continuation of the same response we saw. So we saw that these are durable responses for patients. So you can see on the left-hand side for KRAS mutated patients, the duration of response is 31.1 months. So talk about something that's really clinically meaningful for a patient, as well as the KRAS wild-type patients even had approximately 12 months. So that is something that I think whenever you talk to a patient, it's like an additional year is really very meaningful for our patients. And so 50% of patients with KRAS mutated and 30% with KRAS wild type remained on therapy for greater than 1 year. The discontinuation rate is slow at approximately 12%. And really, you can mitigate any sort of adverse events with either dose holds as well. So it really is a drug combination that you're able to manage quite well. The safety profile, patients could have some diarrhea. They also could get a rash. So we do now know to sort of tell patients to use like clindamycin creams because it tends to be like a facial rash, like an acne form rash. Also, if they go out in the sun, to make sure that they wear appropriate sunblock or clothing so that they can minimize getting like a rash from the sun. And we do see laboratory abnormalities of an increased CPK, but none of those seem to be really clinically relevant. They're more transient blood abnormalities that we see. So, in order to find the confirmatory phase 3, RAMP 301 is currently ongoing and it has the same inclusion criteria. But what's also nice in this trial, because, patients obviously, when they hear about this combination, want to be on it, is that they're able to cross over if they have bigger conformed. Progression of disease. So, if patients get randomized to the chemotherapy arm or the hormonal arm, they're able, if they have progression, to go on to the combination. So I do think that is one way to get this trial performed, and we're hoping that with this larger data set that we'll be able to also get an approval for patients who have KRAS wild type, since currently the FDA approval is only for KRAS mutated patients. So let's revisit our patient case. So Amanda is a 50-year-old stage 3 low grade ovarian cancer who had cytoreductive surgery followed by 6 cycles of chemotherapy and letrozole maintenance, and then recurred 18 months later. She's known to be KRAS mutated. And so the treatment that she was offered at that time was is avutometinib and defactinib. So I would say it's really important to get biomarker testing because based on this, it gives her this opportunity to go on a non-chemotherapy regimen or, trying a different hormonal agent. And then, Bobna, how do you use sort of NGS or ctDNA in these patients? I think that's a burning question for a lot of, our diseases now is ctDNA.
Yeah, no, I think it's such a good question too, because especially for low grade serous ovarian cancers, they're not really high shedders, and so we can't really rely on ctDNA to look for these mutations, and so I think it's really important to do somatic testing with the tumor tissue, and of course, like, the diagnosis is also critical, right? Low grade is very different under the microscope than high grade serous, and if you don't have a really dedicated GYN pathologist, that diagnosis may be missed, and they're treated in very different ways. So I think getting that collaboration with your pathologist, and if you are at like a smaller hospital and don't have a great GYN pathologist, like this is a case if you suspect a low grade to really send that out and get a confirmation of your pathology because it's going to change the way that we treat the patient.
Absolutely. I couldn't agree more. And I think we talked a little earlier about how implementing pill and dosing education. So really having your, nurse coordinators, APPs, NPs, even a pharmacist check on the patient to just make sure they're not having a problem taking the medication. And then I think, for AE management, really the education piece, right? To, let patients know they need labs. They will need to see an eye doctor because they do sometimes get some blurry vision with this. So it is important that they get this, but it's not the same ocular toxicity that you see with antibody drug conjugates. You don't need to take special eye drops for this. So I do think it's a little easier on the patient, especially when you're educating them about this medication combination. And we talked a little bit about the dermatologic sort of how we can mitigate those side effects too.
Great. Thank you so much, Premal. So, lots of exciting advances for our patients with ovarian cancer. And, we've talked about how targeted therapies have an impact, even in rare cancers like low grade serous ovarian cancer, and the critical role of tumor testing, patient advocacy, and clinical trial participation. Thank you, Premal, for joining me today. It's always wonderful to do this with such a good friend and colleague. So, thank you.
Well, thank you, Bhavna, and it's been my pleasure. We hope you found this webcast useful and informative for your practice. Please remember to submit your post test and evaluation for credit and download the slides and practice aids. And thanks again to the audience for joining us because it's always fun to review all the exciting new developments for our patients.